I was tasked to discuss TAVR in women, and I think we have to recognize that there are some differences and challenges that are actually fairly unique to women. Unfortunately, more than 70% of the candidates enrolled in randomized trials were male. And the guidelines seem to emphasize valve calcification as the only difference between them. But they don't look at indexing, they don't look at the other differences between men and women that we have discovered along the lines. So, some of the findings that we know is that women are more likely to present with advanced symptoms, NYHA class 3 and 4. They're more likely to have lower survival rates, and the workup is unfortunately delayed in many of them. And they're more likely, because of these vague referrals and diagnostic tools, to have paradoxical low flow, low gradient aortic stenosis. So when we actually look at this, we see the difference between men and women. The biggest difference is that they tend to have a smaller LV mass, perhaps even though there's similar prevalence of hypertrophy, but they actually have more degree of diffuse fibrosis and higher LV filling pressures, because then your LV becomes much less compliant with fibrosis compared with hypertrophy. But again, circling back to the calcification, we clearly see that there's a difference in terms of the patterns and the degree of calcification. And hence, when we're doing and evaluating patients, for example, with low flow, low gradient AS, and we're looking at Hounsfield units on cardiac CT, the calcification cannot be the same cutoff for men and women because it's far less in women. But what we do see is that finally we've recognized, looking at registries across the board, so whether you're looking at the European population, there's no difference in prevalence, Australian population, and certainly the American populations in the TVT registry. And we found the same in the Middle East. What we do see, however, as you can see in this chart in front of you, is that women tend to have similar admissions, or maybe even slightly higher admissions, but actually the echo and referral rates are much lower compared with men, significantly lower, 36% versus 32%. And so the prognosis is actually different. So when you look at the whole cohort and you look at the overall survival over time, women are less than men, and it starts to separate after 2 years. You see, once again, after in this one, the referral for surgery, so not just TAVR, is actually lower for women compared with men. And looking at discordance of low gradient AS and in men compared with women, once again, you see a big difference. But now in the era of TAVI or TAVR, looking at the TVT registry and looking at survival and looking at cumulative rates, what we do see is that women tend to do better overall in terms of survival. However, the only difference is significantly they tend to have a higher rate in stroke. That's at least from the TVT registry, and perhaps higher vascular complications and bleeding. When we look at patient prosthesis mismatch, we all identify that the higher the mismatch there is, the worse the prognosis and outcome in patients. So with severe PPM, the death rate, stroke rate, and rehospitalization rate is significantly higher compared with patients with only moderate or no mismatch. And women tend to have smaller annuli, even though they may be normal body mass index. And so their chances of having patient prosthesis mismatch is in fact higher. And this is where I don't think, as an interventional cardiologist and as a community, we should be dismissive of root enlargement procedures, minimally invasive procedures that may be useful in women. But my focus is TAVR, but I wanted to make sure that we touch on this. There are two very important trials that in the last 2 years were presented that address small annuli and women specifically. The RHEA trial looked at symptomatic severe AS, randomized patients to TAVR versus surgical aortic valve replacement, and looked at mortality, stroke, and rehospitalizations at 1 year. Now, when you look at the primary endpoint, which was actually a composite, and you look at surgery compared with TAVI, it was significantly lower in TAVI in those with small annuli, of whom over 80-some%, 89% were women. So it did meet the non-inferiority criteria and in fact met the superiority criteria. So when it comes to the primary endpoint, TAVI did significantly better than surgery in terms of death, stroke, and rehospitalization as a composite and as individual endpoints. When we look at the secondary endpoints, however, when we look at atrial fibrillation and we look at permanent pacemakers, pacemakers were higher in TAVI compared with surgery, but AFib was significantly higher in surgery compared with TAVI. And vascular complications, again, were slightly higher in TAVI and pacemakers compared with surgery. Other endpoints like looking at patient discharge home, looking at index hospitalization, time of hospitalizations, and so on, TAVI seemed to do better than surgery there. So in terms of all comers, TAVI with SAPIEN did much better than surgery. In fact, it was superior. They did have a lower incidence of AF. There was better hemodynamics in women with small annuli, and the benefit in terms of having a less invasive procedure in terms of shorter hospital stay and early discharge was better with TAVR compared with surgery. The other trial was the SMART trial, and the SMART trial looked at a balloon expandable platform versus a self-expanding platform. The self-expanding platform are supraannular and consistently in all categories, whether you're looking at low, intermediate, or high-risk patients, we know that the hemodynamics seem to do better with supraannular valve platforms. And again, they looked at an endpoint of mortality, stroke, heart failure, and rehospitalizations. And then, of course, as a secondary endpoint, they looked at valve dysfunction at 12 months. And from the SMART trial, you see that self-expanding valves seem to do better, had fewer events. They also had significantly less valve dysfunction at 12 months, and the hemodynamics in terms of mean gradient, effective orifice, etc., were significantly better. When they looked at some of the quality of life metrics as well, it was better. Now, again, remember the recruitment in small annuli, generally speaking, whether we're looking at the SMART trial or the RIA trial, was over 80% women. And so 86% here were women. When you're looking at absolute differences between self-expanding and balloon expandable, you clearly see an absolute difference that was significantly in favor of self-expanding here. But these were largely trials that were done in Western communities, Caucasian patients. We don't know if in our part of the world, the Middle East, our patients are similar. So when you look at the WIN-TAVI registry that was done in the United States and Europe by Roxana Mehran and Ali Aid Kifu, they looked at VARC2 composite, 16.5% in women at 1 year who underwent TAVR. And they noted that baseline AF and prior PCI were independent predictors of events. We looked at it in the Gulf region where we looked at Saudi Arabia, Oman, Bahrain, and Kuwait. We did the WIN Gulf TAVR registry. It was a sub-analysis, a pre-specified sub-analysis of the Gulf TAVR registry. The composite outcome was 12.8%, death 5.4%, and rehospitalizations was 9.3%. When we looked at the differences between men and women, the composite was clearly higher events in men compared with women. Again, when you look at death, individual components, death was significantly higher in men. But when we look at other events, such as myocardial infarctions and rehospitalizations, it was actually higher in women compared with men in the Gulf registry. So overall, women had comparable outcomes compared with men in the Gulf TAVR registry. We weren't able to detect predictors, unfortunately, because the event rates were actually low. Women had a numerically lower, albeit not statistically significant, higher, rehospitalizations from cardiac causes and myocardial infarctions at 1 year. But their overall survival was actually better. And we're going to need to identify drivers from a much larger cohort, perhaps in the future. But one thing that we know that is different in the women in our part of the world compared with those outside, or in the West in particular, and other registries, is that major life-threatening bleeding was actually lower in our patient population, as well as vascular complications. The baseline demographics and procedural success was fortunately very similar in men and women. But this is what we do see. This is actually one of our patients in the military hospital in Jeddah, where you see that the annulus to left main is actually short in a lot of these patients, the height. And so procedures such as silica and so on become more important here. We're doing laceration, as you can see. We're passing the estato wire into the LV, making the cut. And I think now we're starting to see a little more of these procedures, more refinement, more dedicated devices that can actually be used. And the idea is to prevent coronary obstruction, albeit not completely proof. This is a different patient of ours, again, a woman where unfortunately, her peripheral vasculature was very small, her iliac system. In addition to that, she had significant tortuosity in the descending aorta and a coarctation. It was a bit difficult for us to decide what access route to do, because we did look at alternate access from her subclavian and axillary. We looked at angles, we looked at diameters, and opted to do a 3D printing where we tried to use different platforms and see different access points, if we were more proximal, if we were more distal, and how it would play out. And we finally were able to do a cut down because we couldn't go too peripheral. Her axillary was too small. We actually had to target the proximal subclavian and deploy a evolute core valve in this patient, and she ended up doing very well. This was post-procedure. And you see the kink. Just want as a shout out to remind you that TCT Middle East is going to be in Riyadh, Saudi Arabia, April 9 to 11. You're all more than welcome to join us and share your cases in men and women. And thank you for having me.